All right, well, welcome everybody to the Disaster Response Collaborative Evacuation Focus Area session. We're going to talk about foundations of a strong evacuation plan today. We have a nice setup. We're going to have a panel discussion, a couple of polls, so we can go ahead and get started. Before we get fully into everything, I want to make sure we have the acknowledgments and disclaimer. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. The content presented today is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. For those of you seeking CMEs or CEs, this slide will tell you a little bit about that. I would like to highlight here in the bottom the requirements to claim the continuing education credit. You must attend the entire live session to receive the credit. Ensure you complete the session evaluation at the end. And make sure that your name is on the registration. If someone forwarded you their registration, just make sure that your name on your picture on the screen is your name. And we'll have a slide at the very end that has instructions on how to claim the CE credit with that, with the code. A few announcements. We are really, really happy to have you here with the evacuation team. We're excited about this group. Last month, we introduced each other and we really got to know the teams. We've got a great group. We're going to really get to learn from each other and share. So it's really exciting. We're glad you're back here with us this month. This session is going to be recorded or is being recorded, and it will be posted along with the slides on our website. If you have any questions, feel free to throw those in the chat or the Q&A. Along with CEs for nurses, social workers, EMTs, and physicians, we also offer MOC Part 4 credits for physicians. You can send an email for more information, but we will have more information about that coming up in the next few months as well. I am going to go ahead because I'm going to say this several times throughout the session. If you have any questions at all, feel free to email dncppn@austin.utexas.edu. I'm Julie Shelton. I'm the one who monitors that email and will respond or get the correct response for you. This last box here, we're super excited about. Our focus area web pages are live. And so if you go to the DRC webpage, you will find on the left, there's a collaborative web page. And then there is also web pages for each focus area. So I'm going to throw the one for evacuation in the chat. And you can go there and you can check that out. It tells all things evacuation, why you need evacuation plan, some of the key considerations for your evacuation plan. There's some great resources at the bottom of that page. The most important thing you will want to know is that this is the page that will have your registration from here on out to register for the individual focus area sessions and the larger quarterly full collaborative sessions. The link will be on that page. Here is our agenda today. We're going to talk about a few more announcements. We're going to have a panel discussion, and we're going to have a larger group discussion, a little bit of a breakout session, and then we'll close out with some next steps and closing remarks. A few updates for you from DRC. Again, those focus area web pages are live. Several of you have completed a virtual tabletop exercise in April. Some of you are going to start completing those in April and May and June. So if you are doing a virtual tabletop exercise, make sure that you have completed the training for the facilitator and evaluators. We've got one more live session, which is Thursday. If you can't attend that and still need that training, the recording is available. But you do need to let Chris and David McCarthy know. Those are the gentlemen that are putting on those tabletop exercises. If you're doing your own tabletop exercise, maybe you're not joining in the virtual tabletop exercise, you're doing a hospital facility-led, whether you're doing the virtual or you're doing it on your own, make sure you keep track of those lessons learned. We're going to be asking you about who your participants are. So are they within the hospital? What external partners are joining you? Keep track of your gaps that you recognize, your aha moments, the positives. We want to know all the good, the bad, and the beautiful about your tabletop exercises. This being a quality improvement collaborative, we will start working on those gaps and on those ahas and share with each other. So we'll probably send something out in the next few weeks to kind of capture some of that data from you. This pretty much tells you exactly what I just covered as far as the virtual tabletop exercise. We had gotten a lot of feedback on not knowing the process, and we need a little more clarity on the process. And so we put this together. So again, facilitators and evaluators need to attend that training session. When that training session is complete, the virtual tabletop exercise materials will be emailed to you. And so that's the main trigger to get those materials, is to make sure the training is complete. Then you get to go and have your fun and do your tabletop exercise, and then we'll send out that data collection survey and collect your thoughts on what you learned in that session. Speaking of surveys, this is what we have been waiting for, and it's here, the PDPAC. So the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals. This is a very large nationwide self-assessment that's going to help all children's hospitals assess where they are in their preparedness for pediatric disasters. Okay. And it's not only for evacuation, but we're going to be looking at surge. We're going to be looking at reunification, triage, decontamination, behavioral health, legal considerations. And so it's got all those 11 domains from the EIIC checklist that we've been talking about in one large survey. The key to having this here and not only on a broad national scale, but also a disaster response collaborative scale, is that for disaster response collaborative, this is going to be your environmental scan. Okay, so it's going to be really important. So whether you look at it from a DRC perspective or a national collaboration with all children's hospitals, either way you look at that, the objectives are the same. We're going to establish a baseline. So whether it's within your hospital or globally, we're going to identify strengths and gaps. We're going to monitor the progress as we go along. We'll do this survey annually so that we can see what the needs are, what our individual needs are here in our evacuation sessions. We're going to enhance collaboration and then support community needs. So really important that we do this self-assessment / environmental scan. So what's going to happen is one person from your hospital is going to register. It's kind of like a two-step process. So you go on the website. So your link here, pediatricpandemicnetwork.org news PDPAC. If you go there, that is the PDPAC website, and you can register on that website. You can also use this QR code, and it'll take you straight to the registration. So what will happen is one person will register. It could be the same person throughout the process. And in that registration, it will ask you who your emergency contact at your hospital is. It could be you, it could be somebody else. And once that person is identified, they will get the full big assessment. And they're going to they could break out those 11 domains, they could break those out and send the questions, the different questions to different people throughout the hospital. You can do it yourself, but we suggest to share the love. Let other people help you instead of having to go and ask other people questions. Go ahead and assign them sections, and they can complete that and submit that on. And then the emergency contact will complete everything at the end. So the main thing is to go ahead and register. So the registration and assessment start and open tomorrow. You can go ahead and register, but everything opens tomorrow officially, and then it'll go through the end of May. So not a long time span there. So go ahead and get started on that sooner rather than later. Again, if you have any questions, you can email the DNC PPN. There's also on the website, you can email Anna Bowie if you have any questions. Okay. And I'm going to turn it over to Miss Annette Newman and let her move forward from here. Thank you, everybody.
Thanks, Julie. All right, you guys, let's get down to the meat and potatoes, right? So our objectives today, it's nothing fancy. It's just clear and practical goals. First, we want to make sure everyone walks away today with a solid understanding of what makes up a strong pediatric evacuation plan, what those pieces are, and how they support overall hospital readiness. Second, we're going to talk about what to think through when you're building a plan from scratch, or maybe improving the one that you have. So whether you're early in the process or just refining, hopefully you'll find something relevant from the information today. And finally, we're going to give you a space to look at your own plan and spot any gaps or any areas that you might want to add more or do more to. And this isn't meant to be overwhelming, right? Evacuation is a big elephant to eat. But this session is really about being honest about where we're at and supporting each other with getting stronger. So let's jump in. Next slide, Julie. So you've probably seen this maybe more than once by now. It's the EMSC checklist of essential pediatric considerations for every hospital's disaster policies. And again, we've shared it a couple of times, but this is a fantastic resource. And we're highlighting it today as a resource, and Julie put a QR on it in case you've not taken a look at it before, specifically Domain 5, which focuses on evacuation. And that section touches on evacuation triggers, pediatric transport planning, alternate care sites, if you need to relocate. And while this session isn't directly structured around this, you are going to hear some of these key ideas come up from the panel members today and then from the breakout discussions. So just so you know, it's there to support your work if you need it. All right, next slide, Julie. Well, we are super excited to have two fantastic panelists joining us today to share their perspectives and experience with evacuation planning. First, we have Lindsay Hanway. She is the Healthcare Emergency Manager at Providence Health in Oregon. And Lindsay brings real-world insight, having been directly involved in the evacuation of not just one, but two hospitals due to wildfires. We're also joined by Tanya Trevelyan, a manager of pediatric trauma services at Curley and Children's Trauma Center in Virginia. Tanya is in the process of building an evacuation plan specifically for a PEDS-only floor, and her lens as a trauma leader brings a really important perspective. So we're really grateful to have them with us today. Thanks, both of you, for being with us. So next slide, Julie. This is actually one of my favorite reminders. Forget the mistake, remember the lesson. This, this isn't about perfection, right? It's about progress and learning. And today's panelists will share real world lessons that worked, what didn't, and how they've grown through the process. So next slide. And each panelist will spend just a few minutes walking us through the evacuation planning journey, what they've done, what they're working on, the lessons they've learned, and they'll touch on the type of evacuation they've exercised or planned for, how decisions were made, communication strategies, what worked well, and key takeaways. And after that, we'll open it up for a few quick questions from you. So be thinking about things that you might want to ask both panelists. And with that, I will actually turn it over to our panel members. Lindsay, do you want to start us off, and then we'll turn it over to Tanya?
Thank you, guys. So my name is Lindsay Hanway. As mentioned, I am the Emergency Management Officer for Providence Health and Services, Oregon. Our team services 8 hospitals in the region. And I'm going to kind of go over some of the after action report from what we experienced in the 2020 wildfires that kind of lit the entire West Coast on fire. And so with that, we actually spent some time planning in 2019. We reviewed, can you guys see my screen? Sorry. Oh, not yet. Okay, now you can see my screen. And so we had spent some time reviewing our evacuation plan, and we had gone through an entire process to create an evacuation plan for the whole hospital evacuation post-earthquake. And so that really involved a lot of, power outages and a lot of things not working. And so med sleds and such like that, only for 2020 to hit. And we experienced multiple evacuations, but thankfully we had power. So we were able to test a whole other portion of our plan that we really had not dived into at that point. So let's see if I can move forward. So every star that you see on the screen is a Providence entity that we had at that time. So we have 8 hospitals in the state of Oregon. One of the stars is Benedictine, which is a long-term care facility, and so that's on there as well. But we are kind of congregated around the Portland surface area, but we do have this one little lonesome guy down here in Southern Oregon, right on the tip of California. So starting September 8th of 2020, we got a call in the middle of the night or middle of the day that they had entered a level 2 evacuation zone. So this is long-term care facility with about 115 elderly patients. We worked pretty quickly and kind of gathered all of our resources and said, how are we going to do this? And we established regional command. For us is a lot of key leaders around the region and said, hey, where can we move people and who has open beds and all of that. And we worked fairly quickly to get all of those elderly patients out before that level 3 evacuation order hit by 10 p.m. So we worked with actually 2 separate regions. That one falls in region 2, but a lot of our hospitals are in region 1 for the HPO region communications. So we really got them out and said, great, we did fantastic. That's awesome. The next day hit. So September 9th came around and we got a call from Medford that said their neighboring hospital, which is Asante, they were evacuating because they were in a level 2 zone and said, we need to receive all of these patients, including a nursing home. Within themselves, we had hundreds of caregivers in our staff whose homes were being evacuated. So we had all of that staff had to leave. Ultimately, 30 lost their homes. So we were at capacity. We had all this reduced staffing. Our hospital itself was in a level 1 get ready zone and moving into a level 2 get set zone. So there's a lot of kind of consternation around what was happening at Medford. So we quickly refocused all of our resources to supporting Medford and what that looked like for them. Same day, midnight that night, we get another call that my little baby, one of my favorite hospitals, is about 42-bed hospital out in the Willamette Valley, right on the wine country. It's a beautiful area. And it was in a level 1 evacuation from a fire just north of it. And mind you, they had just received some patients from Benedictine, the long-term care facility. So they were at capacity. And now they had a handful of staff that were worried about their areas on top of everything else that was going on. So that was at midnight on the 9th. Now we have 3 locations that we are monitoring and or in the process of taking care of. This little box is going to break open into what we call the Riverside Fire. So the Riverside Fire started on the 8th, which now we're talking the 9th, and quickly expanded into this spot. So this first star that you see on the bottom here, that's Benedictine. That's the one that we had to evacuate 2 days prior. It quickly moved and they had to evacuate. Now they're at this point. They are in a level 3, so everyone is evacuated zone. And I have one hospital in a green, and I have another hospital in a level 2 get ready zone. And so the first one's Providence, Milwaukee. They were in a level 1 evacuation, so they were constantly monitoring and triaging their patients in case they moved into that level 2. We didn't quite think it was going to happen, but we still had to prepare. And they were receiving patients from both Benedictine, that long-term care, and Willamette Falls evacuation. So here's the big bad one that we had to kind of manage through. So we have a 146-bed hospital that's right on the edge of all of this luscious green, and right before you enter the city. It's about 8 miles as the crow flies from the next nearest hospital. They quickly went from a level 1 to a level 2. They had just received patients from the long-term care facility just days before. Hello. And as we entered level 1, we had to decide, what are we going to do? What are the triggers? When do we evacuate as a full hospital? What does our patient load look like, and things like that? So our tiered plan, tier 1 was our most complex, our time and resource dependent patients. So we had 18, what's called our CAPU, it's our child and adolescent psych unit. We had 2 NICU kiddos. We had 3 in an adult NIC ICU. And then we had 4 mother-baby couplets that we were looking at getting out quickly. The idea at this point is when you're still in kind of that zone 1 of level 1, let's take that time to really find resources that we need. How do we get them out safely so that we're not waiting to that last minute to evacuate everybody? And now we don't have the resources we need to take care of these patients, and possibly putting the patients and our staff in that compromised position where we could have some error ultimately. So with the number of patients number of caregivers, I apologize, that were evacuated. So let's look back out to my map. We have a lot of people that live out here in this these country areas that come in. So they were all being evacuated as well. They didn't want to come into work because they needed to leave to go take care of their homes and their families. Transportation resource constraints. We had all the EMS and fire was like, we can't support right now, or we have very limited support right now. So we were pulling in EMS from other counties, other areas to come help transport these patients out. And then our staffing ratios got very, very wonky at that point. And if anyone knows how staffing ratios can really affect care, which I guess most of you do. So that really impacted our decision making, and what does that look like for those units that were left and those that were leaving. And then we looked at tier 2. Those are still people that were unable to self-transport, meaning I can't just jump in my own car and go. So you're talking med-surg patients and other admitted patients. Those were transported with staff. And so we either put them on an available ambulance with staff, we had a bus come in. It was the same buses that we used at Benedictine prior. So those that were, the patients were ambulatory, we put them on a bus and moved them with some staff up to some nearby hospitals. But other than that, EMS was like, we're done. We can't support anymore. The fire was growing. They were transporting patients and getting everyone out. Our staff was getting scarcer and scarcer as people were leaving the hospital. And we really started to have to make some critical decisions. We got down to tier 3, which was anyone else that was ambulatory or able to self-transport. So if I had an ED patient that I could say, look, can you drive your car to the next one? And they did. So we had to make those calls as far as EMTALA, what does this look like? All of that came into consideration in those moments. We have to evacuate the hospital. Are you safe to stay? Are you not safe to stay? We ended up with never having to fully evacuate. We left 7 patients, mostly were ED. We had 1 laboring mom that we were really concerned about transporting her mid-labor with everything else going on. And the skeletons crew and with facilities, engineering, and staff. So that's who was left in the building when we kind of finally called it and said, we kind of held tight until we got the okay that we were no longer in a threat. So what were our big communication issues? There's a lot going on the slide, and I apologize, but we had massive amounts of, as you saw, that many hospitals are on fire, that many hospitals are either accepting or moving patients and things like that. So there are a lot of different pieces of those puzzles and multiple puzzles happening at once. So it was a lot. We did utilize our staff emergency hotline for caregivers. They were getting updated information since they didn't necessarily have access to their emails offsite. We did utilize existing email tools to provide real-time notifications for all of these things. And we were really encouraging those caregivers to, hey, sign up for your city, your fire department's Twitter accounts or emergency alert systems. Please don't let us be your first point of contact when we need to say it's time for you to start evacuating. Make sure you're signed up with those guys. And then we also used our Everbridge mass alert system to let people know what was going on as well. We communicated heavily with media and used our social media messaging to kind of go over hospital conditions and what was happening. But then one-on-one, we had a whole team focused on communicating with families that their loved ones were being transported. So who's leaving, where they're headed, did they arrive on time? Yes, we have Grandma Sue. She's good to go. She's safe here, etc. So we kind of had both pieces of the puzzle to let them know that it was happening, and then when they had arrived, safe. Within ourselves, we coordinated so much with the county. We had every hospital that was involved had every command center opened up. And then that was just to kind of prep for level 1 evacuations. And then per our EOP, anytime we have more than 1 hospital activate for any different reason, even if it's the same reason or not, we open up area command. So at this point, it was the Oregon Region Command Center. We did multiple briefings, multiple coordinating calls between our Patient Logistics Center, which is our transport team. And then we had lots of calls going on with fire, with EMS, our health and medical MAC group, other EM counterparts. So in our region, we have like Legacy and Kaiser and Oregon Health and Science University. And so we have lots of other hospital systems that we were coordinating with, our HPO liaisons. Oregon Nursing Association got involved because we were transporting their staff, and there's contracts around all of that. And then Oregon Health Authority, Government Affairs, and eventually the Oregon National Guard. So what went well? I use this picture because if you have not experienced wildfire season, it is orange outside. You open your door and it is a blanket of orange. And so you can't really see much, but I wanted to kind of give you guys a visual of what they were experiencing in that moment. So ultimately, we created a labor pool to support evacuation efforts. We had a whole team go to the hospitals in to Benedictine to start evacuating. So they were coming from their safe zone, heading into the quote unquote fire to evacuate those patients out while it was still safe. We did engage external resources like Oregon National Guard and Lifelight. This was a call on our part to say, we need extra resources. We definitely did not have the numbers that we needed between staff and the people to actually do the moving. We just couldn't do it. We didn't have the transport teams. We didn't have the EMS teams. So we made a call, got the Oregon National Guard commander on the phone, and he said, we'll be there. And they did, and they showed up. We ended up had a staff, and we had to supply local hotels for patients. All the SNFs were full. So remember, this is COVID time. So every SNF was full for COVID reasons. Now you have this going on and so we ended up saying, let's just utilize hotel rooms. And we had to staff them and actually supply hotel rooms. It went fairly well, and it was a really big concern for a lot of reasons and obvious reasons, but it ended up in that moment and ended up working. We transported staff with those patients. That was one of the biggies of you know, if a staff member could drive themselves versus going with the ambulance, we looked at all of those pieces of the puzzle. And then we actually housed that staff either at the new hospital and gave them beds and things like that to sleep at the new hospital they were arriving at, or we gave them a hotel room. Our kitchen was fully engaged. We had lots of extra people on site between the new hospitals and everyone that was kind of getting juggled around. We dipped into our 96-hour plan because resources were scarce across the region, and then really started to focus on upticking all of that information. We had 6 hospitals receive from the one main hospital, the Providence Willamette Falls. 3 of them, of the 6, were themselves were in a level 1 evacuation. So they are constantly triaging their own site to evacuate while receiving new patients on top of it. The CAPU unit patients were securely transported to 3 different behavioral health facilities using county and state police. So they did secure transport for us, which was fantastic. EMS was not going to provide that amongst everything else. So we used the Oregon State Police and we used our county resources to transport them up. We did have sometimes we had nurses go with that transport in the front seat since they couldn't be in the back, but in the front seat, or the nurses just followed the police car to the new location and then was with the patient the entire time. National Guard actually returned all of our patients to us in one fell swoop. So it was great when we repatriated, they all came back at the same time, which was fantastic. We had multiple times a day, health supervisors were constantly updating their census and acuity and ambulatory lists to see who needed to evacuate, who needed to get triaged out, etc. We had some of our other side note takeaways and things to think about on a larger scale, not just the clinical side of it, is we had our facility managers and our environment of care leadership really in a lot of conversations as to how to close and reopen a hospital as necessary. These are conversations they had never really thought about before, how to fully shut down a hospital at night. So we created a lights out team for a worst case scenario. And we had to identify what that would look like if we did have to turn off the water. Obviously, concerns like Legionellas and things like that start to pop up. And then we had to determine, you know, can we turn off the MRI magnet? What does that look like? What are the side effects of that? So all of those different things. With the 30 caregivers that lost their homes, we had HR programs that we sent out for affected caregivers. We sent out gift cards. I think we had 20 some odd got motorhomes, like RVs, and we put them up in an RV so they had a place to sleep and a place to stay without being in a hotel. We gave them so much support that we could from our hospital scenario, and this was all, you know, kind of till 2020, not yet impacted COVID times, financial constraints. So supported them as much as we could and wrapped our arms around them. Ultimately, the best news was that 0 patients were harmed during this entire process. Last slide, our lessons learned. Our regional resource hospital actually transferred 2 of the NICU babies from Willamette Falls to Providence St. Vincent's in the metro without notice. So we had 2 NICUs. Sweet little babies arrive without preparation. Our pharmacy and our facilities and engineering teams did not have a evacuation plan. Facilities and engineers, they basically built it as a plane was flying type situation. But ultimately, we never sat down with those 2 teams and said, how do you close down? You know, what medications do you need, et cetera, et cetera. And so that was one of the takeaways to really focus on and build out that plan if we ever have to finish that process out and shut down the hospital. We did not have a solid logistics section. That was on us as the EM team. We got everything we needed and we tracked everything going in, but then didn't do a great tracking process of where everything was to get returned once we were back to normal operations. And then we identified pretty quickly that we were learning information from fire and city emergency operations teams as it was being posted, just like everybody else. So they were not providing information to us in real time. We would get provided to once it got posted on Twitter or once it got posted on public information websites. That's when we were notified of changes, such like evacuation zone changes, things like that. So we realized that there was nothing that could tell us any differently, and we needed to place ourselves in that EOC in order to get communications much, much faster. So ultimately, my biggest takeaway for any of you that are building an evacuation plan, if you have to fully evacuate the hospital, is that every single department needs a plan, not just clinical. And they need to have a slow evacuation plan. If we do this timely, what does this look like? What order are we doing it in? What's the triage order of the patients? What else do we need to do? And then there's that like fire evacuation plan. The house is on fire. We got to get everybody out the doors right this second. Just go, right? And so those were kind of our biggies. I think we had one plan in place and then tried to build the plan as we were flying it for the second portion.
As you were talking, Lindsay, that was making my armpits sweat. I love fire. It's been my life prior to this and still is, and that's just super sketchy and right in the middle of COVID too. So hopefully some of you took pictures of those fantastic lessons learned from those slides, and we'll see if we can garner some of the information and pass that out as well for those that weren't able to capture it. Tanya, let's move over to you. Thanks, Lindsay.
Hey, yeah, no, unfortunately I have no slides, so you just get me. But yeah, what we found, let's talk about some of the things that have happened at our organization that we kind of weren't under the impression that we were missing it until we started looking. So with our evacuation policy, we have women's and children's services we're a hospital within a hospital. So what we found when we started to look at evacuation policies is that the NICU has an evacuation policy. Our mother baby area unit has an evacuation policy, and labor and delivery have an evacuation policy. But the 11th floor where the pediatric patients are, so there's 24 pediatric floor beds as well as 8 ICU beds on that floor, has no current evacuation policy, which could be a problem if we need to move patients out. So, what we found is that, within our organization, we're a hospital within a hospital. So sometimes when planning efforts happen on the adult side, it doesn't always trickle over to the children's side. So because of that, we have to kind of squeak the wheel a little bit so that we can get to be a part of that planning process and part of things that they create for the adult side that would work okay for the ped side, or at least get peds input on. What we also found within, looking at internal processes, because again, we're kind of like the new kids working on this. By trade, I was a PICU nurse for a long time before I became a manager of trauma services. Yes, I helped build our trauma program and got us designated, but disaster was not within my wheelhouse before this role. So I wanted to we take time to learn as much as we can, but we also know that it's limited with what our inpatient staff learns. So they don't necessarily get training on a consistent basis. What they get, and I will never forget, is we get evacuate west if there is a chance that we would have to move patients out of our area. So that there is a west location. So where PICU and PEDS are located are on the south tower. So we would horizontally evacuate to the west side of the hospital, but that might be challenging if the west side of the hospital is full. Formerly, there was an adult inpatient area there that has kind of dissipated to now a discharge planning area. So it kind of is only used throughout the day for folks who need a little bit of extra stuff before they get to go home. So it's kind of like the discharge lounge, but an inpatient discharge lounge, if that makes sense. So again, they still have private rooms over there, which will allow for folks who have maybe infectious conditions that they can't be in a communal discharge area. They kind of wait there. And most of those are adult folks that kind of stay on that side. So when we looked at this evacuation policy, obviously we knew we needed to create one. So that's where we started. I can't say that we've brought this evacuation policy that I've kind of took the bare bones from all of the other 3 policies to kind of piece one together to make it work for our areas. what we did with that is send it on to life safety, because how many people in this room outside of the people who do emergency management for living know where the smoke compartments are on each individual floor and where you could safely move a patient to if we needed to temporarily evacuate. Again, these are some other logistical things that we had to kind of think about, and we had to pull in those experts from that team to help us with that piece. Our team does plan. So once we get the policy written and where we want it, we'll put it through policy approval process. Once that happens, our team plans to create, have an exercise with it. So what we thought was a reasonable start would be a tabletop. Again, it's a walkthrough. So we could kind of talk through the process, walk through the process in an environment where it's kind of safe to say, I don't think that's going to work, or I think that's going to work well. So again, tabletop allows us for that, to get that feedback and suggestions of what, hey, we want to put this in place, but we're not sure that this is going to work, and to kind of work out the bugs before we do a full scale exercise. Because at some point it's reasonable to consider that needs to happen. I mean, think about it. How many people within combined centers or other facilities have disaster exercises or full-scale drills go beyond their ER? Because we are a facility that historically all of the disaster exercises that have been planned and brought through our second floor ER don't go past the second floor. So again, some other things that what we can think about, again, when you're talking about a high stress, low frequency situation, there's going to be some confusion on who's responsible for what. So right now, there's really no written guidance for our inpatient staff. Okay. So it's kind of an interesting thing when you think about, these are the folks that are going to be there around the clock. What if this is 1 a.m. on a Saturday? Again, those bedside folks are going to be the ones who are going to get the alert and the notification that we've got to do something. So we do have plans outside of the evacuation policy with the tabletop to look at maybe job aid cards or one-page reference. Why? Because it helps them to understand this is what you're responsible for if this is your role. Again, it works well in other areas. And when I've talked to folks throughout the PEDS Pandemic Network and some of the projects and things I've been involved with, I found that it was something that worked well and was easy to kind of replicate and customize it for your area. So again, that's something that I think we're gonna definitely talk through. Once we get that evacuation policy, we're gonna make sure that we kind of have that reference card on hand so that folks know this is what I'm supposed to do and this is what I'm responsible for. I like this one. Evacuation triggers in your decision-making process. So when we look at that, you have to consider for all levels of evacuation. So a lot of times we think, oh, well, we were always told evacuate west or evacuate horizontally. We never really considered the vertical evacuation or total evacuation. So that's the other piece of it too. I mean, think about it. We're on the 11th South Tower. If we go up to the 15th South Tower, that's where our heliport is. So that's where we can get aircraft to kind of bring patients to us, but take patients out of the hospital via air. And that would be, we would have to figure out how to get there, especially if we couldn't use the elevators. So that's something to think about. And then of course, the total evacuation, if we don't have to evacuate the hospital fully, but maybe we just have to evacuate the 11th floor, what's our plan B for location? Again, we've always been told evacuate west and not beyond that. So we would have to think, where's our plan B area that could really accommodate our patients and meet the needs of those folks that we have to move. And would that mean that we may have to transfer the patients to another area that could give them, maybe they have a similar bed at another facility. So those are all things that we want to make sure that we consider. And again, what works well for other areas may not work well in pediatric care areas. Again, we have to think about the patient type, the family presence, and clinical needs. Think about it. We have some long-term care kids that don't always have family members at the bedside. So we have limitations with that resource. Again, like I said, lack of knowledge related to where the smoke compartments are. I mean, again, bringing in the life safety folks to help us with that was definitely helpful. And I'm pretty sure that we have plans to have them labeled so that folks know exactly where they are. So if we do have to do that small evacuation, maybe we have to temporarily move for a little bit to stay in a safe zone, we can move to where we're supposed to. Again, and I like this communication strategies during an evacuation. So when we think about that, again, we will definitely have incident command activated, but then again, who's going to be the point person for the pediatric area? So we do have administrators on call. We actually do have, nursing directors on call. We have typically have a floating charge nurse on the pediatric area too. So, again, who's going to start that process and who's going to be the lead entity of this evacuation? Is it going to be a tiered teamed approach? Again, that's kind of all the things that we're in the process of exploring, because we have to make sure, number one, if we look at this, what resources do we need in order to make it happen? Communicate processes that worked well. Again, we haven't tested it yet. So surprise, again, once we test it, we'll let you know, but we're hopeful that, again, some of the stuff that we're going to put into place will lead to an effective evacuation policy. Again, what we found when we found we were lacking one, that's kind of a challenge that you have no guidance to go by. So think about it. We don't have job aid cards. We don't have any of that stuff as a resource in our nursing care area. If they needed to look up a policy, they wouldn't be able to find one for their area. So that again, we wanted to make sure that we addressed that piece. Again, and what do we know? What have I learned about disaster over time and learning and participating in a lot of these fun things like the networking collaborative and the scholars for PPN, as well as this response collaborative, is that there's a lot of layers to disaster science. And, again, we're still learning. We're still trying to figure out the best ways, and definitely making sure that we do what's best within our organization. And, maybe we share it with other people if we do something well, or we put something together that's effective and good and seems to work. We can make that happen. Again, partnering with other team members is imperative, and connecting with really smart people, like the bunch of people in this room, bunch of people through PEDS Pandemic Network. Again, I love the fact that you can connect with people who are willing to share their information and what worked well for them, so that we could develop an effective process here that may prevent us from reinventing the wheel. Think about it. If we're a hospital within a hospital and there's another hospital within a hospital that put together a good process, well, let's look at our similarities and what we could use from that piece. Some other lessons learned for me over time is, again, keep learning. Any opportunities you have to learn more about disaster planning and all of the things related to that will help on the journey. Connect with other people. A lot of the folks from fire and EMS know a lot about disaster. There's a lot of folks, again, nationally, that know a lot about disaster. And there might be people in your backyard that you didn't even think about. I've been connected with our local healthcare coalition as well, and they are a great resource for some things too. And I like, again, don't be afraid to speak up and ask questions. I never am. I am one of the wheel squeakers. So I will not be afraid to ask questions. I definitely like to get involved. And I can't say that I don't interject myself in meetings that I feel strongly that need a pediatric presence, because I do it all the time. And keep that persistence, keep moving forward, and don't let challenges get in your way. Again, if we find that plan A doesn't work for evacuation policy, we'll have plan B. And if we have to go all the way down the alphabet, we'll make sure that we keep working at it with that opportunity for improvement in order to make it the best process for the kids we care for. And that's what I have.
You guys, both Lindsay and Tanya, did some fantastic review of lessons learned and some best practice tips. If you have questions for either Lindsay or Tanya, can you put them into the chat just for, we'll be a little tight on time when we got dinged last time, so I'm determined to stay on time this time. But if you have questions for either, please reach out. Tanya and Lindsay, also, if you could put your email in the chat box, and then people can reach out to you individually, then that would be a way also to get your burning questions to either of those two. But I love that folks put "let's share" in the chat, because there's definitely lots of things that we can share. We are going to go into some polling right before we break into our breakout groups. So I guess, Julie, polling questions? And these are just to get a quick pulse on where everybody's at. So the first question that Julie will bring up will help us understand the starting point for the PEDS evacuation planning. And there's no right or wrong answer to this poll. It's just knowing where we are as a group. I see your face, Julie. Should we skip poll?
And you should be able to see the poll and where you're getting results in.
There's some great data. Thanks, everyone, for helping us to gather this so we can, again, look at resources that people may need. Should we call it good, Julie?
Looks like it's steady.
It looks like most folks have a plan, but are working on improving it. 64%. So our second poll is an area that we know is often overlooked. And I love, I think it was you, Lindsay, that mentioned that you had a child and adolescent psych that was evacuated, and actually National Guard helped you return them, which I thought was really a great practice. But these, we know, are some of the gaps that many folks may have in their plans. And so this would be really helpful for us to know, so we can maybe pull in a speaker specifically around this. Great. We call it good, Julie? All right, and this is the fun part. So this is a crowdsourced moment. So for those of you that can participate, please drop a word or a phrase in here if there's one element that you think is absolutely essential in an evacuation plan. And maybe it's something that hasn't been mentioned yet, something that you think deserves more attention. But it would be great to see what rises to the top as a group. I know that I think it was Lindsay also mentioned a unified regional command, and that was one of the lessons that has also came out of the Hawaii firework New Year's Day incident, too. Just the importance of that unified communications and command. This is great. Weather. That's a great one. That's actually one of our biggest on this. So tracking, event, weather, patients. All right. Julie, shall we move into breakouts? And so thank you, everybody, first of all, for the great input on the word cloud. There's like super great energy there. We really appreciate you. We're going to move into breakouts, but we'll only have, let's see, 10 minutes or less whenever Julie pulls us back. And we'll go into small groups and delve a little deeper into a few key questions. Kind of look at those biggest themes on that word cloud, and then move into challenges, and finally strategies or resources. Depending on where we get, we may get into the children and youth with special healthcare needs or behavioral health. But then there should be a facilitator for each of the breakout groups that will help guide the conversation, and then come back and give a very short summary of those groups too. So we will break into groups, and then we'll see you back here in 10 minutes or less. Does that sound good, Julie?
Great.
All right, Pat, you get to talk first.
Okay, well, anyways, we had a really nice discussion. We pretty much gave everybody a chance to do a little round robin about what the things jumped out at them. Certainly, number one was patient tracking, how to keep track where patients were going to be going as far as that's concerned. And the fact that some people hadn't even thought about having to track, their staff as well. The other one was communication and coordination. And the third one I would say would be associated with people knowing what the chain of command was, in terms of their roles and responsibilities, and how to make that pretty, straightforward, people on the same page. And we talked a little bit about going back to incident command structure and making sure that people understand how that can benefit decision making, and also solidify roles and responsibilities even on a small unit basis.
That's awesome. I can, sounds like you had a great group. I can report out really quickly for group 2. I was a little late, but we had some fantastic information. The first gap that was noted was staff familiarity with NICU equipment, specifically related to staff turnover, which was problematic. And then we went into a great conversation about, utilizing the med sleds during a fire drill. So strategies and resources to kind of incorporate, to operationalize some of this would be during a fire drill at the hospital to pull out the med sleds and have staff use those. And then we got into a deep conversation about, packing a couple of kids on a med sled versus on an adult med sled. And I guess there's inserts that can go on them. So you can utilize an adult med sled for multiple pediatric patients to get them out. And then there's, I think it was Kathy, I can't remember, but the use of a Barry med sled to wrap equipment up and get equipment down on a Barry sled, which I thought was fabulous. And then the other thing that was brought up by Zach that wasn't in the word cloud, that he was surprised wasn't there, was training and exercises, which is, as we know, really problematic, specifically around staff time and getting that just-in-time training is not always the best. To have done it prior to is a really great thing. So I think that's a report out for our group too, unless I missed anything that was essential. Kathy, I think you're up for 3.
Okay. I would say the biggest thing my group talked about was the difficulty with patient tracking. And so we kind of talked about the some of the things that the speakers had mentioned that were good things to steal. In the sense of we really like the get ready, get set, get go, and kind of how would you do tracking and getting ready for tracking, and that type of, we're at a get ready stage, we're at a get set stage, we're at a go stage, and you're planning and a way of educating staff. And then we also talked about the idea of an awareness of, who had parents there and who didn't, because then you have pediatric patients who actually have an adult with them versus not. And then I would say one of the other issues is the concept of, if you are the IT center for your city or your area, or maybe even your state with kids, how do you transport some of these kids out? Like, who is capable? And so that was really talking about just the different levels of evacuation, and it really depends on what the event is, and sometimes the concept of sheltering in place, and you know, whether you keep kids like that or not, and the importance of throwing in innuendos of that into tabletops to bring up those discussions so people start thinking about them now and coming up with solutions to them now.
That's great. It sounds like there were some fantastic discussions in all groups. We, Julie, so we'll go to next slide, but in the interest of time, we did have Catherine Harris and Jack Smith who are going to share about their TTX. We'll capture that next time, just because we want to be respectful of everybody's schedules, and then we'll skip this large group discussion. So Julie, I will turn it back to you to close us out. Thank you, everyone. This has been a fantastic session.
Yes. Thanks to everybody. Thanks to Tanya and Lindsay for speaking and telling us about your evacuation. So again, some things to consider and talk about and think about as you leave today. Our upcoming sessions, we've got the full collaborative session, which will be all 4 focus groups coming together. I put the link in the chat so that you could register, and also there's a QR code for that. Instead of app for that, now there's QR code for that. And then we will reconvene with the evacuation focus area group in June and July at the same time. So just make sure that you notice the time change. In May, we will go back to the 1 to 2:30 Central Time. For the CEs, here's your code, WAPSAZ. We have changed just slightly the sign-in and the portal to put that code in. So the instructions are here. It's just a slight little change on the sign-in. It's more of a global sign-in option. But that'll talk to you about how to do that. But I think you might need to create a new password for that. So instructions are here. You can take a picture. We will send this out, and it'll also be on the web page as well. Here's the QR code for the evaluation to get the CEs and/or just to let us know any feedback. So we are taking your feedback. We are implementing that, and we were changing. So please give us your feedback. Again, that is also in the chat if you need that link instead of the QR code. Thank you again to everybody who came today, participated, who spoke and shared your stories. That's what DRC is all about, and we're going to have a great 1.5 years coming up as we continue on. And all of those doing your virtual tabletop exercises and hospital-led tabletop exercises this month, good luck, and I can't wait to hear from you. Thanks, everybody.
Bye.